Weiss is speaking today. He's a current child and adolescent psychiatry fellow in our program. He obtained his bachelor's degree in psychology from Illinois State University and his master's in biomedical sciences from Midwestern University. He went to medical school at the Arizona College of Osteopathic Medicine and did his internship at East Tennessee State University. He then transferred to the University of Toledo to complete a psychiatry residency, where he was also chief of research and scholarly activity. His talk today is titled Agitation Under the Microscope, Neurobiological Mechanisms and Pharmacologic Strategies for Acute Management. Please welcome Dr. Andrew Weiss.
Thank you, Dr. Rickfeld. So good morning, everybody. Today we're going to look at my presentation titled Agitation Under the Microscope, the Neurobiological Mechanisms and Pharmacologic Strategies for Acute Management. Again, I'm Andrew Weiss, a PGY4 here at Phoenix Children's, and completing my first year of Child and Adolescent Psychiatry Fellowship. To start, I have no financial disclosures. Today's educational objectives wanted to describe the neurobiological pathways and neurotransmitter systems involved in agitation. Also wanted to evaluate the pharmacologic agents used to obtain rapid calming for acutely agitated patients in various clinical situations. So a little background on why I chose this topic. I chose agitation because it's something we deal with frequently in psychiatry, and it seems to be getting more and more common. We saw a threefold increase in IM medication use from 2009 to 2019 for agitated patients. So it's not just psychiatry. I think it's happening all over. And data kind of supports that. It shows that 73% of staff at a pediatric children's hospital reported evidence or experience with violent situations. And out of those staff reported experience with a violent situation, 75% of those were on general medical units. There's a lot of hospitals around the country that have less access to psychiatry. And so I think it's important for everyone to get more comfortable with agitation so that we can get better outcomes for the patients and the staff. And let's start by defining agitation. There's multiple definitions for agitation, and I think this reflects the complexity of the syndrome, where the DSM defines it as the inability to sit still, pacing, hand-wringing, pulling or rubbing of the skin, clothing, or other objects, and disruptive motor or vocal activity, whereas the FDA and some of the research defined it as symptoms ranging from pacing and restlessness to verbal and physical aggression. In 2016, there was an international expert group that came up with the definition of a state where patients cannot remain still or calm, characterized by internal features such as hyperresponsiveness, racing thoughts, and emotional tension, and external ones, mainly motor and verbal hyperactivity and communication impairment. But regardless of the definition, I look at agitation as an acute behavioral emergency that requires intervention. And when looking at agitation, we tend to break it down into three categories, being mild, moderate, and severe, where mild agitation is things like fidgeting, pulling at clothes or hair, that hand wringing, nail biting, some difficulty sitting still, and some irritability. And then it escalates a little bit more to moderate, where it's raising the voice or yelling, making threatening statements, pacing, rocking, throwing small objects, but not really aiming at others, lightly scratching without breaking the skin, hitting lightly, or brief head banging. I guess I consider low intensity head banging for this to be moderate. But it goes to be more severe when you're seeing behaviors that place the patient or others at imminent risk of harm. And that includes attempts to assault others, moving or throwing large objects, destroying property, strangulation attempts, attempts to cut or deep scratching of the skin, or more of that like forceful or prolonged head banging. Today, we're going to focus more on kind of the severe agitation, and I did underline kind of these behaviors that place patients and others at imminent risk of harm, because this, and in some contexts, moderate agitation, are the times we're more likely to use that pharmacologic interventions. And looking at some of the genes associated with agitation, we find that there are some variations, especially in genes that affect dopamine and serotonin, that have been associated with aggressive behavior. And although agitation and aggression are not technically the same thing, they often present together, and especially when we're talking about that severe agitation. Um, and there's a lot of overlap between the agitation and aggression as far as like the genetic underpinnings. And when we're looking at that, we look at genes that really work on things like dopamine and serotonin a lot of times, like DR, D3, and DRD4, which encode dopamine receptors D3 and D4. They're expressed in the prefrontal cortex, the striatum, the limbic regions, and these modulate dopaminergic signaling involved in executive function, reward sensitivity, emotional regulation, and impulsivity. Variants in these genes can alter the receptor function, which impacts things like behavioral inhibition and causes an increased risk for externalizing behaviors. Another dopamine one is DAT1 or SLC6A3, and these encode the dopamine transporter, which is responsible for the reuptake of dopamine from the synaptic cleft, which regulates the dopamine levels. So polymorphisms in these receptors can affect transporter expression or function, which then influences that dopaminergic tone, which can contribute to hyperactivity, impulsivity, and disruptive behaviors. Another one is COMT, and that encodes catechol O-methyltransferase, which is an enzyme that degrades the catecholamines like dopamine and norepinephrine in the prefrontal cortex. There's a polymorphism called the Val158 MET polymorphism that affects enzyme activity, leading to reduced degradation and higher synaptic dopamine, which then is associated with increased aggression and emotional reactivity. Other things like MAOA, which encodes monoamine oxidase A, and that degrades serotonin, dopamine, and norepinephrine. So low activity MAOA variants result in higher synaptic monoamine levels, particularly under stress. And there's a good amount of data out there that links this to increased risk of aggressive and antisocial behavior, especially in males and in the context of early life adversity. Then we have the serotonin transporter, SLC6A4, which regulates the serotonin reuptake. The 5-HTT-LPR polymorphism affects the transporter expression. The short S allele is associated with reduced transporter function, altered serotonergic signaling, and increased risk for aggression and emotional dysregulation. Although we kind of look at these genes, we associate them with increased risk of agitation. When we're looking at acute agitation, I tend to look at disruption to or kind of underdevelopment of neurocircuitry when I'm trying to understand it. And there's three kind of disruptions to the neurocircuitry that I look at when I'm looking at agitation, that kind of acute agitation, and they're all kind of connected together. First is the amygdala-centered kind of bottom-up activation. And this is the amygdala detecting a threat and engages the brainstem and limbic regions like the locus ceruleus, the bed nucleus of stria terminalis, the anterior insula, periaqueductal gray area, and the hypothalamus. And so it triggers a stress hormone response. And when it's overactive, it can kind of amplify agitation. And usually we have kind of this top-down cortical control as the second way that I look at how agitation can be happening. And this is the medial and orbital prefrontal cortex, along with the anterior cingulate cortex. And normally these moderate the threat responses and enable some behavioral restraint. But when the prefrontal cortex control weakens, emotional reactivity dominates. And in children, the neural circuits underlying agitation, irritability, and aggression are characterized by immature integration and segregation of emotional related brain networks. So looking at things like the amygdala, prefrontal cortex, anterior cingulate, they're underdeveloped compared to adults. And so this functional connectivity between the regions is weaker and less differentiated. So they already have lower top-down control just at baseline kids because of the developmental kind of period they're in and their brain continuing to develop. Then we see the stress-induced shift in cortical engagement, where we see that typically norepinephrine has the highest affinity for alpha-2 receptors, alpha-2A, which is the most abundant subtype located in the prefrontal cortex. And it will preferentially bind these receptors when you're in a low-stress environment. And just so we all remember that alpha-2 receptors in the CNS tend to be considered sympatholytic. They reduce norepinephrine release from the presynaptic neuron and produce more sedation when they're active. But in high stress environments, the excess norepinephrine starts engaging alpha-1 and beta receptors. And this extra norepinephrine release may bias some cortical activation towards more posterior and inferior areas. And the individual's ability to think and consider different behavior options may be diminished in those high stress situations. So it shifts processing away from the prefrontal cortex to more kind of primitive emotional brain areas, reducing the rational control. And I also try to understand some of the neurotransmitter changes that are happening in agitation, where we look at which ones are increasing and which ones are decreasing in that setting. So we look at ones that increase, like the catecholamines, dopamine, and norepinephrine, and they increase, which then increases arousal and threat perception. Both the locus coeruleus and the ventral tegmental area project to the amygdala, fueling kind of like this acute agitation that we were just talking about. And so other neurotransmitters that increase are acetylcholine and glutamate, and those also drive, cortical and limbic excitation, which can worsen threat interpretation and decrease in some inhibitory systems. And then ones that are reduced that we associate with aggression are GABA and serotonin, where that reduced GABAergic tone impairs the inhibitory control circuits, like between the prefrontal cortex and amygdala. So you get more of that unchecked emotional response. And low serotonin, kind of reflected by reduced 5-HT1AA in the spinal fluid, is linked to poor impulse regulation and heightened aggression. But, it's not only a psych thing when we do see that agitation. There can be several disease processes where we see agitation in the hospital setting. The etiology of pediatric agitation is often multifactorial. And during acute agitation, it may not be realistic always, like in an ED setting, to obtain a complete history before needing to address the agitation for patient and staff safety. But when it is possible, like say they're mid to the floor and we kind of already know what's going on, it's important to determine that etiology contributing to the presentation of agitation, because it helps us guide more of a targeted agitation management strategy to optimize outcomes. Like, for example, if we're looking at agitation in the context of seizures, like let's say the patient's having post-ictal aggression and uncontrolled seizures, we may want to avoid medications that lower the seizure threshold, like some antipsychotics. And looking at kind of like the neurotransmitter breakdown, where during the seizure and immediately following, there's usually that increase in GABA, but then after there's a decrease in that GABA below baseline for a period. And so, when trying to utilize that too helps us choose things like medications that work on GABA, because maybe it will help bring that GABAergic tone back to baseline, maybe just as like a secondary way to help with that agitation by restoring the neurotransmitters to what would be kind of like a normal level, and also not make the seizures worse, at least if they're uncontrolled. So, but comparing this to a patient, let's say, who's admitted for an infection, they get delirious, and while they're delirious, they become aggressive. In this context, we expect an acetylcholine deficit just based on delirium. And in delirium, we also see that excess dopamine. So here, if we use an anticholinergic medication, or really any sedating medication, it may worsen the situation by kind of increasing that acetylcholine deficit. So here we may go with an antipsychotic with low anticholinergic properties to decrease the dopamine and not worsen that acetylcholine deficit. But there's several causes of agitation that we see in the hospital. Some causes here listed in the chart, it doesn't cover everything because it's very extensive, but things like TBI or seizures that we just talked about, encephalitis, pneumonias, electrolyte disturbances, or hyperglycemia. Even things like heart failure is associated with increased risk for aggression. Environmental toxins, medication reactions, like especially ones we use or even an overdose attempt, thyroid or parathyroid issues, even just some constitutional things like poor sleep. And then also those psychiatric things like autism and intellectual disability, psychosis, mania, catatonia, substance intoxication, substance withdrawal. So there's a ton of things that can cause or contribute to that agitation that we do want to be aware of because it helps us in kind of guiding that treatment better. There's also risk factors for agitation. There's a study done looking at these different risk factors for agitation in pediatric ER, and they found factors like having a prior history of acute agitation, especially in the previous 24 hours, history of abuse or victim of violence or trauma, if they have a communication barrier like an autism or a developmental delay, male sex, if they have an existing mental or behavioral health condition, things like chronic disorder, DMDD, ODD, if the patient's from a foster care, a group home, if they were incarcerated. They found that these were all risk factors for the patient to display acute agitation. And so far we've looked at, the genetics, the neurocircuitry, some neurotransmitter changes, while keeping in mind differential diagnosis and risk factors associated with agitation. So now let's start looking at kind of how to handle these situations when they arise. When I was going through this process, I looked at a bunch of different agitation algorithms to kind of get an idea. And most recommendations follow this flow for acute agitation, where you always start with verbal de-escalation, ensuring safe surroundings, followed by pharmacologic intervention. And most have restraints being the last resort for the pediatric population. And this is because restraints are considered the most restrictive. Here, I think this is a snapshot from Children's Hospital of Philadelphia, one of their algorithms, where they kind of show you the most restrictive, least restrictive. And that's because the restraints are associated with worse outcomes. Today, we're going to focus more on the pharmacologic interventions that can be used when verbal de-escalation fails, when the agitation's at that level where it's unsafe and we have to use a medication. You always want to offer a PO option first, but today we're going to focus on when you can't get them to take a PO or they're unable to take a PO for whatever reason. And so really focusing on those intramuscular medications that are available for acute agitation that have some evidence in pediatric population or have at least been looked at. So again, pharmacologic treatment is indicated to treat the moderate or severe agitation when verbal de-escalation fails and when we need to promote safety. So one issue when looking at these, which we run into a lot of times in pediatric psychiatry, is that there's a lack of data. There's only been a few rigorously designed studies assessing the effectiveness and safety of these medications for acute agitation in children. And so the current body of evidence includes like one randomized controlled trial, a handful of some observational studies conducted in ER departments, pre-hospital settings, and inpatient psychiatric units. And we kind of base current practice on these studies, what we know from them, in combination with clinical experience and taking what we know from adult literature and just based on some consensus of experts. So let's start evaluating medications that we could use for IM when the patient is acutely agitated. First up, antihistamines like diphenhydramine and hydroxyzine. We tend to use first-gen antihistamines due to their ability to cross the blood-brain barrier when they are, or where they're antagonists at that H1 receptor, which then reduces wakefulness. They also possess anticholinergic properties. And again, we talked about in most cases that acetylcholine tends to be high, so we want to decrease that a little bit. With these medications, you do want to avoid them in delirium because it may worsen that confusion. You can cause some paradoxical reactions with disinhibition in some people, even though that's pretty low risk. They do say it's higher risk in the younger children, those with autism and intellectual disability. Remember, they can cause QTC prolongation. And if you're giving a bunch of doses, we have to worry about that anticholinergic toxicity where you'd see it's possible hallucinations, confusion, dry mouth, tachycardia, urinary retention. And although diphenhydramine is a very commonly prescribed PRN psychotropic and is often favored because it's we kind of consider it safe. We're familiar with it. It's easy. It comes with IM, PO. There's plenty of routes to give it. There was a small RCT that involved kids age 5 to 13 where it actually didn't separate from placebo when you're looking at agitation. So, this is a medication we try because it's safe and it does work for some people, especially if they're smaller, less risk of harm to others or to themselves. But yeah, it didn't separate from placebo for agitation. It did reduce agitation, but didn't separate from placebo. An interesting thing from that study was that the IM route was more effective than PO, even when you're giving the placebo or the diphenhydramine. So maybe there's some aversive conditioning going on there too. A lot of times we'll add this medication in as a combination treatment for agitation, a traditional kind of combination, something called the B52. But I think they're finding that it may cause more harm than good. Wasn't studied on kids, but actually at Banner, they did an adult study comparing the traditional B52, which is Benadryl 50, haloperidol 5, and Ativan 2, to just 5-2, which would just be that haloperidol and Ativan. And the B52 combination resulted in more oxygen desaturation, hypotension, physical restraint use, and longer length of stay in the ER. And there's no difference in administration frequency of additional agitation medications between the two. But they did note that patients who received just that 5-2 were more likely to receive an antimuscarinic agent within the next 2 days. So maybe it helps reducing those side effects, but you always have to kind of do that risk benefit with this. So overall, it's a frequently used medication. There's no strong evidence to say that it works better than placebo for agitation. We do try it, and it's a very reasonable choice. And more of that moderate agitation range, or when the risk is a little bit less. But if this is, a 17-year-old huge linebacker who's very agitated and is swinging at people, I'm probably not going to start with an antihistamine just because of the lack of evidence there. Smaller kids, it's a reasonable choice. Next up, we have the benzodiazepines, which work by enhancing that GABA transmission. So hopefully adding to that kind of top-down control. So some common agents like lorazepam, midazolam, diazepam. Most of the data on the benzodiazepine used for agitation in pediatric population are from retrospective studies. And effectiveness is based on more on the low rate of repeat medication administration. But there was an RCT that looked at diazepam orally versus olanzapine orally. So we use benzodiazepines kind of preferred for most substance intoxication other than alcohol. Maybe benzos, or maybe not, and benzos or other kind of things that would contribute to that respiratory depression. Things like catatonia, it's great for patients who are severely anxious and become agitated. But this is another one you want to avoid in delirium because of that risk for worsening confusion. Does have some side effects that we're probably all aware of, like that respiratory depression, especially in combination with other meds, hypotension, and there is that paradoxical agitation or disinhibition, which is rare, but it can happen. And looking at the pediatric data, that RCT that I just briefly mentioned that looked at the oral diazepam showed that at 1 hour post-administration, about 57% of the pediatric population had adequate sedation without the requirement for additional sedatives. That was a PTO trial. It's a fairly recent one, and they have a PGM trial looking at intramuscular routes, which will be interesting to get that. And there was also a separate pediatric ED study where they found that about 2% of youth or people under 20 had a paradoxical reaction to lorazepam. Another study showed that it was about 1% of youth, so I guess I consider it 1 to 2% for that paradoxical risk. There's several case reports that also indicate, again, people with autism or intellectual disability are a higher risk. I couldn't find any data on it. It mostly comes from experience in these case reports. Next up are the antipsychotics, which are kind of the class of medications I think about when I think about agitation. We tend to break antipsychotics down into, first and second generation, where we have more concerns for things like the EPS, the extrapyramidal symptoms. In the first gen, they have less of the 5-HT2 binding and tend to be more potent D2 receptor blockers is why. Where the second gen, you tend to think a little bit less EPS with some other different side effects. And we also kind of break these down into high potency and low potency, where the high potency ones have that higher affinity for the dopamine and less for things like alpha and muscarinic receptors, where the low potency tend to have lower affinity for dopamine and more for that alpha, muscarinic, and histamine receptors. But when you're kind of looking at the whole group, they all block dopamine D2 to some extent. There's a risk for EPS. The dystonia is something that you watch out for if you're using these as kind of an acute medication. Things like those sustained contractions are what you have to worry about. Ocular gyrate crisis, laryngeal spasm. We can't treat this with Benadryl or benztropine. Another thing like akathisia you have to watch out for, which is that inner restlessness where the patient feels like they have to have this constant movement. And we could also try to treat this, not as successfully, but using things like propranolol or benztropine or benzo. A lot of the antipsychotics have this QTC prolongation risk, which can increase risk for arrhythmias, goes to torsades and then VFib, and that can be fatal. So it is something you really have to watch out for. And so having that cardiac history is important. And you always want an EKG if possible, especially if you're using multiple doses. Other things like orthostatic hypotension, NMS are things you want to watch out for, where NMS, it's kind of like that fever, rigidity, altered mental status, and autonomic dysfunction. Labs might show an increased CPK, and this is something you really have to watch out for too if they're getting these medications a lot or if they're on other medications. And so with that, you want to stop the antipsychotic and use some supportive care. But let's kind of look at the individual groups here. So again, because I'm focusing on IM routes, it limits it to about 5 medications. And so when we're looking at the first generation ones are all available. All 3 of these are available as IM, PO options. And so first is haloperidol. And this one's a potent D2 receptor antagonist with minimal anticholinergic or autonomic effects. It's often administered in combination with lorazepam for patients with severe agitation, kind of that 5-2 combination we talked about before. IM administration is recommended over IV because of IV has an increased risk for QTC prolongation and torsades compared to IM or PO. And adding in that benzo or even adding in that Benadryl may be considered if you want to reduce the risk of EPS. And haloperidol is actually probably the preferred treatment option, or one of them, if you're going to be treating someone who's acutely intoxicated from alcohol. And looking at the data on haloperidol, there's a retrospective study conducted that looked at oral immediate release haloperidol for acute agitation in the pediatric emergency department. And it found using kind of a mean dose of 4 milligrams had a response rate of about 36% at 1 hour, which was not needing another medication and adequately sedated. They did have EPS reported, so you have to be careful with that. And I guess that's lower than I expected of a response rate, but then considering it's oral, usually when I've used it, I've had to use it IM for the agitation. And looking at oral, it tends to peak after that hour mark, at like 1.7, even up to 6 hours. So I think that 36% would probably be increasing as time goes on, but a lot of these studies measured at 1 hour. So compared to an adult study that showed it was about double efficacy of that 36% at an hour. So a little bit different data there. Next one is chlorpromazine or thorazine, which has a long history of use in treatment of agitation. It's low potency, but highly anticholinergic, very sedating as a medication, maybe the most sedating out of these IM medications that I'm going to talk about. And this was a frequently used medication. There's a retrospective study on kids admitted to a residential treatment program in Canada, and it was actually the most frequently used medication for agitation. And in that study, they had no reported side effects other than drowsiness, no EPS, which is interesting, and no hypotension that was reported. So in that same study that we talked about earlier with the oral haloperidol, also included oral thorazine, the chlorpromazine, and found that oral chlorpromazine had about a 50% response rate at that 1 hour mark. So a little bit better than the haloperidol at that 1 hour mark when used orally. But again, we're talking about IM today. We don't have the data on that, unfortunately, in pediatric population. But it's important to know that some places don't use that chlorpromazine IM. Looking at the NICE guidelines, which is the National Institute for Health and Care Excellence from the UK, they recommend against IM chlorpromazine because of limited quality data in adults and the higher risk of adverse effects like the hypotension and cardiac concerns. I've also been told that it's a very painful injection. I think it's like a very viscous injection. So something to keep in mind, where a lot of the algorithms don't even include it actually in theirs, and some places are more comfortable than others in using it. Next one is droperidol, which is a first-gen antipsychotic used to treat agitation, and this belongs to the same subclass as haloperidol. When I was in med school, it wasn't taught about, I think because it got this FDA black box warning for QTC prolongation, and then because there are these case reports of torsades with it, manufacturers stopped making it and it kind of just fell out of favor. But there are some subsequent studies and reviews that showed that it's probably not any higher risk than the other medication to use. And it's been widely used for agitation in adults with very few adverse effects reported. There was a study of 12,000 adults with no occurrence of dysrhythmias, and recent studies have demonstrated it's pretty safe and effective in children and adolescents. For instance, there's an observational study of droperidol for pre-hospital acute behavioral disturbances in children, and it had a median time to sedation of 14 minutes, with about 8% having some adverse reactions, some like hypotension, dystonia, respiratory depression. So that's a pretty fast onset. And with most of the patients getting adequate sedation under 15 minutes, that's an excellent choice probably, and one that I think we're going to start seeing more and more, and that ERs around the country seem to like already. And the other positive is that the sedation lightened at about an hour, which is interesting because it gives us an opportunity for kind of earlier reassessment of the patient depending on the setting. And that's something to keep in mind because if the longer the patient's sedated, the less options you have to kind of get that information. So this medication did have more of a rapid control of agitation than the Haldol, which was kind of like the gold standard when I was training adults, what I thought. And they even looked at a combination of the droperidol and midazolam, where they found that compared to the haloperidol and Ativan combination, they found 10 minutes after giving it, 51% in the droperidol and midazolam group were adequately sedated, compared to only 7% of the haloperidol or diazepam. So something to keep in mind, that this is something that we should probably start utilizing a little bit more, is that droperidol. But again, all three of these have risk for the QTC prolongation and EPS. Then looking at the second gen, we have olanzapine and ziprasidone, which they aren't usually broken down into the potency, but I guess they're considered more moderate potency, where olanzapine has also some moderate anticholinergic activity. It's available in IM, it's got an oral dissolving tablet, which is awesome too. And this is a good medication. There's several studies that have supported its effectiveness in the treatment of agitation in youth. A retrospective study for kids admitted to a residential treatment showed that olanzapine was more likely than lorazepam or thorazine to produce adequate sedation within 30 minutes. And only about 17% in another study required another medication. It's got less risk of QTC, which is a positive, and we use that a lot because of it, and is pretty safe. One of the articles that kind of looked at all of the different medications and reviewed all the evidence also kind of chose this as their preferred medication for acute agitation. You do have to worry about giving it within an hour of those benzos, so be careful. And that's based on some historical studies, but it's for a different talk. And we also talked about that previous RCT that looked at the oral diazepam versus olanzapine, and it showed that about 61% of the patients in the study had adequate sedation with the oral medication in an hour. Then we look at ziprasidone. Again, moderate potency. It's got low anticholinergic activity, but a lot of side effects on the heart. And this one, in a retrospective study, showed there was no difference between the efficacy of this and olanzapine, looking at restraints or duration of restraints or just the efficacy of medication. But it did need more doses throughout the stay of the hospital, not necessarily like immediately after, but throughout the stay. It had more doses required compared to people who were given the olanzapine. Also, there's another study that showed really no difference between ziprasidone and Haldol, so something to keep in mind. Next up is ketamine. This one is an NMDA and glutamate receptor antagonist. Works by blocking the NMDA receptors. Ketamine disrupts excitatory glutaminergic neurotransmission, leading to a rapid onset of dissociative anesthesia, characterized by sedation, amnesia, analgesia, and I think that it works on agitation kind of due to just those dissociative properties. And so it works by pretty much dissociating the patient and stopping that agitation pretty quickly. It can be given IM or IV for that agitation. And looking at a retrospective review of 911 EMS records, they found when looking at patients under 18 who were treated with ketamine versus benzos, it showed that ketamine had a higher likelihood of clinical improvement at 88.8% versus 70% with the benzo, had fewer additional medication requirements after the ketamine, being only 12% needing additional medications versus 27% in the benzo group. And marked sedation was more common with that ketamine, with 28.8% becoming markedly sedated compared to 2.9% with the benzodiazepine. The study also said that it was similar rates of that ventilatory support that was needed between the two or advanced airway placements. Neither were significant, but, an adult study kind of went against that, where it looked at ketamine for rapid sedation and meta-analysis in pre-hospital emergency settings, and it showed that intubation occurred in about 30% of the patients. So I don't know if it was just the study or the dosing, or maybe kids require it less, but it is something to keep in mind. Because this medication can be dangerous when using it for acute agitation. But based on an adult study, it's the fastest medication to get sedation, with average time being about 5.8 minutes only for sedation in the context of acutely agitated patients. So it's got its risks, but it works really well. And depending on the setting, it might be something that you would consider using. But it is a tricky one. Our algorithm here at Phoenix Children's doesn't include ketamine, but there are some that do. Here I have Johns Hopkins, their children's hospital algorithm for agitation. They do include it in theirs down at the bottom here. But it's always noted as for refractory agitation or violence. So really only for that really severe. So this is the case where it's like, that 17-year-old linebacker, if they came back, they're on meth and they're extremely aggressive, maybe ketamine is one that you consider for that, just for the rapid sedation due to the danger of the situation. And a lot of these studies that we talked about seem to use kind of repeat administration as a marker of medication being effective or not. And looking at that, most agitated youth require only one dose of medication. There's this retrospective study of about 128 pediatric patients that showed 13% of them received 2 doses and only about 5% needed 3 or more doses. And so when you're using repeat administration, a lot of times you want to use that same one that you've already tried just to avoid adverse drug interactions. But you do have to consider other options if you had no benefit at all, depending on what's going on. So here's a nice picture that kind of shows those areas we talked about earlier in the circuitry of agitation. And then it also shows some of the medications we talked about where they target, which is awesome. Kind of that heightened catecholamine activity from the locus coeruleus and ventral tegmental area, excessive dopamine in the amygdala and prefrontal cortex, the diminished prefrontal cortex control. It shows here, like you could see atypical antipsychotics. It shows how it works on the D2 receptor here, and also that 5-HT2A with some 5-HT2 or 5-HT1A activity. And also it shows how it works kind of on the alpha-1 receptors too, some of them, where here it's got the high potency one showing more of that focus on the D2 receptor. Benzodiazepines here working kind of in the prefrontal cortex to help with that inhibitory control. They did include propranolol up here in the picture, and there is some evidence for propranolol use for agitation in certain populations like autism, intellectual disabilities, TBI patients. It really helps to decrease the autonomic arousal that is associated with agitation and provide that calming. But data is limited to only PO formulations at this point from what I saw. So that's why I didn't really include that. Or even like the alpha-2 medications, which you'll see on a lot of the algorithms for agitation at various pediatric hospitals, including ours, if you look at them. Some, potential future options that I could see being beneficial because they have either, different routes of administration if you can't use IM or PO, or a different class, kind of like this dexmedetomidine. Sorry, I butchered that. The Precedex. They created a sublingual film, which is FDA approved for adults for acute agitation associated with schizophrenia or bipolar disorder. It acts as a selective alpha-2 receptor agonist, providing some sedative and anxiolytic effects. And it did demonstrate efficacy in reducing agitation within 2 hours of administration. It hasn't specifically been studied for non-psychiatric aggression, though, but I think it would be beneficial, and I think it's already used in other formulations for this. It does have those side effects, which are mild, like some somnolence, some dry mouth, dizziness, hypotension, but at least their trials didn't have any serious adverse effects. Another one is inhaled loxapine, which is also FDA approved for agitation in bipolar and schizophrenia in adults. And this is another first-generation antipsychotic, but it's got this novel inhaled route that offers an onset of action similar to IV, which was around 10 minutes. So that's something that would be a fast onset, less invasive than kind of sticking someone with a needle if you don't have to. Had lower risk of EPS compared to some other first-gen antipsychotics, like the haloperidol and things that we talked about. But there was a risk of bronchospasm in patients, especially if they had respiratory conditions. So something that if this does come to market for our use, or if we do start using this, to be aware of. Another one is sublingual asenapine. It had some evidence from a randomized double-blind placebo-controlled trial in adults that demonstrated at 10 milligrams, the sublingual dose of asenapine did significantly reduce agitation. So another medication that's coming in a different route that may be beneficial for us to use. But again, no data on agitation in the pediatric population. And previously I've been talking about these algorithms from different places. Each one's slightly different, but kind of has the same main ideas. I recommend everyone goes and checks out the one that we have here at Phoenix Children's, our agitation algorithm. It can be found just by searching agitation on PCH's index. It was too large for me. It was like 7 pages, covered the whole page. So I couldn't put it all in these slides, but I did want to show you little parts of it because I do think it represents an awesome kind of like stepwise approach of how to deal with agitated patients. It covers things that aren't just IM medications. It's got the dosages of all the different meds, time to onset, repeat dosing recommendations, things to look out for. So it's good to know, good to look at, especially if you're dealing with it on your own and you're not very confident. It kind of helps build that confidence for you. Here you can see it's talked about considering first choices like the antihistamines, benzos, alpha-2 medications. So these are, PO, but a good starting point. Then it offers up kind of second choices if it doesn't work here, where it's looking at the atypical antipsychotics and the typical kind of like our first gen, second generation antipsychotics. And then kind of things to consider at each step. It also provides dosages, repeat dosing strategies that I was talking about before, those onset effects. So it's got everything you need in there to kind of help you make some good choices. And I think the best part about the algorithm is kind of right here at the bottom of the page where it says, consult psychiatry for further guidance if needed. So I always think, when in doubt, consult psychiatry for these agitated patients because it is something that we deal with frequently. So to quickly summarize agitation, it's got a multifactorial etiology that it's important to be aware of. Looking at things like the neurocircuitry, the neurotransmitters that underlie agitation, and keeping in mind there are some genetic variants that do increase the risk. There's very limited pediatric evidence on treatments, unfortunately, at this point, being a very hard thing to study. So you do want to choose medications based on the etiology that you're working with and considering the side effects of that medication, either for its benefits or to avoid those side effects when you're making your choice. So that's kind of my quick and dirty look at agitation and at some of the IM, well, really the only IM medications we have available for acute agitation. So now I'd like to open things up for any questions or comments that people have.
Thank you, Dr. Weiss. That was very interesting. What are your thoughts on kind of used dosages in the pediatric populations, knowing that the data comes from adult, what dosages or what kind of proportion of the adult dosage would you typically use, and what do you take into consideration for deciding on which dose to use?
Yeah, so I think depending on kind of the situation being how old the kid is, how large the kid is, like if it's that example I use, like that 17-year-old linebacker is probably going to be a higher dose, closer to that adult dose than I would use in, let's say, a 5-year-old, 55-pound kid who's never been on any medications. So that's the other thing is kind of if they've been on medication or not, the severity of the agitation and kind of the risk that it presents as far as, how big and aggressive they are. So that's really what I'd consider. Yeah, it's hard because the studies aren't there yet. There's a current study going on called the PGM study. That's an RCT looking at some IM medications in kids for acute agitation. So that'll be interesting and maybe give us some information. But yeah, you typically want to do lower doses than you would in adults. Some algorithms do offer weight-based dosing, which is a good way to look at it too. Some break it down into like under 80 pounds or over 80 pounds. And so there's no real perfect way to do it, but being cautious, I guess, would be the takeaway from that.
Hi, Andrew. That was great. This is Kara Lewis. I enjoyed it a lot. My question for you is on that algorithm that we use here for PCH, which is, huge and helpful. Do you feel like it is where it needs to be? Do you think there's anything that we're missing on there, or do you feel like it's always helpful? I know you said, for example, we don't use ketamine. which is, a difficult medicine to use in a lot of ways, but Phoenix Children's does use it for a headache group. So I know it's a medicine that we're comfortable using. So is that something that you think would be useful at some point in the algorithm, or really not? Or is there anything else?
I think that probably depends on kind of setting. And again, yeah, provider comfort. I think in a place like the ER, maybe having it there as an option would be something that I would more readily consider than, say, on a psychiatry unit. Because just knowing that adult data on how many people did require intubation, I'd be hesitant to use it in a place where they're not really comfortable in doing intubation if they had to do that right away. So that's why, the ER being maybe more comfortable with that compared to like the example of the psych unit. But I think this algorithm is more just for a generic overview. And I think with the evidence that's coming up with that, like droperidol, midazolam combination being, pretty quick to sedation also, I think there's some other maybe safer options to use. But yeah, if the provider's comfortable with it, then, that's kind of the goal, is to be comfortable with the medication that you're using.
Thank you.
I have no further questions. Thank you. I want to thank Dr. Weiss for an excellent presentation. Thank you.